Thank you, Neeraj. Today, unfortunately, we've been stuck in OT, so I'm still in the hospital. But anyway, we'll go through the cases, which are quite interesting in their own right. So hopefully, one second, I have to share my screen first. Is that visible?
Not yet, sir. Yes, sir.
Yeah?
Yes, sir.
Okay, so we'll start with the first case. This is a 12-year-old gentleman involved in an accident. He had a very significant injury to his right hip, but no other injuries, and was in another city elsewhere in another state, and was initially given traction, and he presented to us 5 days post the injury. He was fit and otherwise stable, no other problems, but that were the x-rays of his hip. So, Neeraj, would you want to?
Neeraj, sir? Maybe. And one more person is here. I think if you're able to answer. Yeah. Yes, sir. You are joining. Sir, so it appears like
Rajan, okay, Rajan can give his comments. You just have audio on, you don't have to have your video on.
Rajan and Neeraj is here. Yes, sir. You are able to hear?
No, I think maybe
yes,
Rajan.
Yeah, actually, it is a 29-year-old male having an accident 5 days back and presented to us. Can you read the X-ray?
He is otherwise stable, no other significant.
So this is a radiograph of pelvis, pelvis with both hip joint AP view, showing right head of femur fracture.
Okay.
There is.
What about testiculum?
Yes, there is.
Okay, Neeraj, will you add something?
I don't think he's there. So on to the CT scans.
Yes, sir. Neeraj is responding,
okay.
Sir. Yeah.
I don't think so. Yeah. Okay. So it doesn't matter. Go on to the CT scans. So now, can you tell anything from the CT scans, which is anything from what you saw earlier?
The posterior wall of testiculum fracture.
Yeah, I'm asking Neeraj Rajia. Yes. No problem.
Approach B.
Sir, first of all, we should try close reduction if possible. After that, open reduction.
Okay, so would close reduction be possible here?
No, sir.
The one fragment is lying outside and one fragment is lying inside.
Yes, sir. Sir, close reduction is not possible.
The head is gone with the fragment. You can usually there's one small fragment lying inside, and the main head and neck are outside. Then you can reduce it.
Yes, sir.
Whatever pull you will do will not affect the head fragment which is lying outside. Yeah.
Yes.
So it has to be an open reduction. And where is the head lying?
Sir, superior pole of.
Posteriorly. Okay. So this is lying posteriorly, and the superior pole of the acetabulum is also fractured posteriorly. So yes, you have to go posterior first. Okay. That head fragment you will have to retrieve. Okay.
Yes, sir.
You will need to fix the acetabulum. Whether you do that earlier or later, that is your choice. But for the head, you would then need to do a safe surgical dislocation. So that's the head fragment. Okay, then we did the trochanteric osteotomy, flip osteotomy.
Yes, sir.
Then you take the safe surgical dislocation, and there's the neck and the missing fragment in the head here. Okay, see that? So there we put the head back there, fix it with screws, then you put it back, reduce the head, and then you put in just 2 screws to fix the trochanteric osteotomy. Because this is a flip, it will fall back and stay. You don't need very robust fixation of that trochanter. Okay, and then obviously the acetabulum has been fixed. These screws in the head which are holding it, and that is the postoperative. This is the image and the x-rays postoperatively. Okay, you can see how the trochanteric has fallen back, the head fracture has been nicely reduced, and the acetabulum is nicely fixed. So what do you expect in the follow-up?
Is a chance. So it is type 4 Pipkin's fracture, and maybe a chance of avian we cannot ignore.
Yeah, it's the very high risk of avian, because not because it was just a type 4, but because it's an unusual type 4 with the head lying outside. Okay, that's not the standard type 4 fracture dislocation where you have the head with the neck out and a fragment lying in the joint. Okay, and with the acetabular fragment. So here, obviously, if the head has been totally out for 5 days, there's a high risk of avian. Anyway, so those are the other views, the obturator and iliac views, again showing a good reduction. And this is a follow-up. This is at about 3 years, I think, follow-up. He's still doing quite well, but if you look very closely at the x-rays, there are some signs that there is likely to be avian. Okay, but he's lasted now for almost 4 years, 1.5 years, I think. He hasn't come back for follow-up for some time. We have to try and get him to see him again sometime to know how he's doing now. Okay, so the next case, this is a 45-year-old male with an injury to his foot. And basically, it was an RTA. He came and his foot was stuck between the clutch and the brake, and it got twisted. And he came with these x-rays and clinical picture. So again,
Subhanshu is present.
Yes, sir.
Yeah.
What do you see here?
Sir, there is a talus arthrodesis.
Sorry?
It's history of trauma is there.
Sir, there is a dislocation of talus, sir.
Talus dislocated or the subtalar joint?
Subtalar joint dislocated, sir. On inspection, sir, there is a groove in the heel area, sir.
Okay.
And ecchymosis is also there, sir. And sir, it's dislocated, sir, laterally.
Okay. It's a dislocation at the level of the subtalar. It's gone laterally, but anteriorly also, yeah?
Yes, sir.
See if you talk about the displacement being on the distal fragment, the posterior facet, which should have been under the posterior facet of the talus, has gone almost to the anterior part of the talus, yeah? And it's lateral to the talus on the AP view. Okay?
Okay. Okay, sir.
Now what will you do? This is the patient who's presented to you.
Sir, first, it is, sir, we have to do the emergency reduction, sir, in OT.
So, urgent or emergent closed reduction in OT. Okay, what else?
Yes, sir. Sir, then after external fixator, and then I
So
like
you
to do
would
the.
reduce it and then do and put on an external fixator.
Yes, sir.
So Janki can mention what he found in the OT when he did the close reduction.
Yes, sir. So it was not reduced easily. So I have put a calcaneal pin, and after that, it with the traction, it gets reduced.
Okay,
And
so you have calcaneal pin and traction on the pin.
yeah.
Did you and then maneuvered that posteriorly and medially?
Yes, sir.
And you could get it reduced. Did you have to invert or evert the foot particularly?
So it was
Invert.
yeah, invert. Actually, sir, after the traction, easily it gets reduced just
Came
after
back
the
down.
putting calcaneal pin. So,
And was it stable after reduction or was it unstable?
sir, stable.
Okay, so anyway, you reduced it and you put on an external fixator, okay?
Yes.
Unstable is what it said there, which is, okay, so you put on a spanning fixator. It wasn't a very stable reduction, obviously, okay? And then you did your CT scan. Then we did a CT scan, okay? So now what do you see on the CT scan?
Sir, calcaneal fracture, sir, on the medial side. Anterior process fracture of the calcaneum with ankle joint is normal, and subtalar joint congruence is not maintained, sir.
Okay. So where do you think the fracture is? Is it a standard calcaneal fracture or something different?
Sir, there is a medial Sanders sir type. I actually AB, sir. I don't know.
Firstly, it's not Sanderson, it's Sanders.
Sanders, yes.
I don't think the Sanders classification comes in here. This is a fracture involving which part of the calcaneum?
Sir,
What is constant fragment of calcaneum?
yes, sir. Sustentacular tali fracture and constant fragments.
So it's not a constant fracture. Normally the sustentaculum tali is the constant fragment, okay? Is
Yes,
that
sir.
it doesn't get fractured in the normal calcaneal fracture, okay, which goes through the is a fall from a height or something where the talus gets impacted into the calcaneum. Huh? So here it's a different mechanism.
Yes, sir.
It's like a twisting thing which the calcaneum has got driven out and the talus has fractured the sustentaculum tali. Yeah.
Yes.
So you have to have a different approach for this. And what approach do you have to use?
There is two approaches: sinus tarsi approach and lateral calcaneal approach, sir.
Why do you need a lateral calcaneal approach?
Sir, actually, sir, this is a medial side sustentacular tali fracture, sir. I don't know, sir.
So you will have to use a medial approach, okay?
Okay.
Okay. So medial approach to the sustentaculum tali. What are the structures you need to think about there?
Like
Fracture proximal shaft of femur with
sir, there is a neurovascular vessel, sir, and
Okay.
flexor helictis.
Posterior tibial vessels.
Sir, flexor helictis.
Okay. So you have the
Posterior
vessel,
tibial artery and vessels. Sir.
tibial nerve and the posterior tibial artery. Okay. You have the flexor hallucis longus, flexor digitorum longus, and the tibialis posterior tendons. Yeah.
Yes.
Okay.
Sir. Yes. Okay.
All of these. So you need to know your anatomy to be able to keep these safe when you're approaching it from here. And then you have to find the sustentaculum fragment, reduce it, and then fix it, okay? So that's the approach. You can see the medial approach. That's the fragment there. Then we reduced it, where if you're trying to see, that's the fragment that you're moving there. And then we fixed it provisionally, first with K-wires and then with screws. Okay. So there are two screws fixing the fragment there. Okay. That was the post-op picture. Okay. So now everything looks okay.
Yes.
Yeah. So you can see now the axial view showing how the sustentaculum has been fixed, and the lateral view again showing the fixation in proximally, distally and proximally. And this is his functional outcome at 6 months follow-up. So you remember that not all calcaneal fractures are the same. Okay. You need to assess the injury both in terms of bony and soft tissue injury. Dislocations generally need to be reduced urgently because of various factors, skin problems, vascular problems, etc. External fixators are useful for temporary stabilization, and fixation should be planned after appropriate investigations. Okay, so now we go to a third case, which is a 60-year-old gentleman, trochanteric fracture. I mean, this was 7 years before he came to us. This was fixed with a Jewett plate. Any of you know what a Jewett plate is?
No, sir.
No?
No, sir.
It was one of the implants used before the advent of the sliding hip screw or dynamic hip screw, okay, which was a fixed angle plate, okay. So this fixation failed and the implant was removed 2 years later, but this patient did not come to us till 5 years later because this was the original fixation. Okay, so you can see the screw, the nail is very close to the, it's got a tri-flinch head on it, close to the joint. You can see that the trochanter is not reduced. Okay, this 11 months the implant was removed. This is how he came to us at 7 years post-op. Okay, those were the X-rays. I think we had a CT, but we don't have it here. So what are the issues that you would need to think of and what would you do? And there's, he's a 56-year-old gentleman, so fairly, was fairly active, etc. before this happened.
Yes, Neeraj.
Sir, there is.
Yeah.
Yes.
Sir, previously
Okay,
it was a
I'm calling
trochanteric.
Neeraj Raj Maharishi. Don't confuse here.
Sir, previously it was a trochanteric fracture. It was fixed with Jewett plate, sir. Now the implant has been removed, sir.
Okay.
Instability is present at, sir, the fracture side, sir. Mode of fixation should be, sir, as the joint space is maintained, sir, there is no sign of any arthritis.
Okay.
We can go for, sir, osteotomy with fixation, sir, with platings.
So what osteotomy, what fixation, what plating, and where's the trochanter?
Sir, trochanter is superiorly migrated.
You think it's superiorly migrated or see the lateral X-ray?
Posteriorly migrated.
So can you do an osteotomy with the trochanter lying there?
No, sir.
So what do you have to do?
Other option you can think of?
Replacement, sir.
There is.
Yes, the replacement is an option, but even that would be a little complex because you still have to reconstruct the trochanter. Okay.
Yes, sir.
Because,
Age is
the proximal fragments, the medial part of the proximal femur, That beak, sir, is medial beak. It is quite long.
Yeah. So
That is another problem. That I think you can call it Kale variant, sir. Is this
who?
Kale variant? What he was mentioning?
Kyle variant. No, Kyle
Yeah,
variant.
Kyle variant.
Kyle variant is a fracture going into the neck. This is originally a fracture of the trochanter with the problem having after fixation. And the trochanter also is off. So here you have to think of all these issues. Okay. So you have the fracture displacement, bone quality, because by now it's osteoporotic. The articular surface looks okay, but there was at one point a suspicion that it may have penetrated, but not enough to totally damage the joint. And the trochanter is lying there. Okay. So you need to get that back into place. So when you're reducing it, you have to get the head reduced to this and the trochanter reduced to that. And your fixation has to look at all this. You have to do an osteotomy, maybe add bone graft and also wire the trochanter back in place. Okay, so that's what we did. And the other thing was the previous track of the blade. So you have to try and find bone where you can go into. So if you look at this, this is deliberately placed a bit posterior. This is the ischial tuberosity. So this is the head. So we've deliberately placed it a bit posterior because that was where the good bone was. Okay.
Yes, sir.
This is 6 months post-op.
So this is a locking type of DHS.
Yeah, this was a locking. This was a locking DHS. And this is 6 months post-op. This is 12 months post-op.
Yes.
And this is 16 months now. Everything has gone on to heal well. The only problem is we haven't got a clinical. So there's a person, the person who got this patient to us keeps coming back with other patients. And he said he got him back once, but that time I was not here. I think Dr. Thakur saw him, but he didn't take the photographs, etc. So unfortunately, although this is now, this was done many years ago. I think this last follow-up was in 14 or something. So this was done while we were still working in Poplar Nursing Home. We don't have a more recent follow-up on him, okay? Which is sad. Okay, so this is post-traumatic deformity of the distal femur, where the fracture is healed in varus, but he develops pain in the left knee and varus deformity, which is further aggravated. So when you see him walk, what do you see?
That is varus thrust, sir.
Yeah.
Present.
Okay, so
On left.
for the postgraduates, but anyway, there's a definite varus thrust when he's walking, and I'll just show it again so that maybe I have to back it in. Yeah. So if you watch the video carefully, you can see how when he's putting his weight on his left foot, his knee is going, and it's better seen from the back. You see how his knee kind of goes in when he walks, yeah? So that's the classical varus thrust. So here you have to analyze the deformity, because although most varus problems in the knee are in the proximal tibia, here's a case where it is probably both tibia and femur. So you draw your axis, you draw your mechanical axis for the femur, okay? And then you see the angles. So you in the femur, you see the mechanical lateral distal femur angle, which should be again around 85, 90. So this is much more. And in the tibia, you see the medial proximal tibial angle, which again should be around that much. And here it's less. So you know you have a deformity both in the tibia and the femur. So how will you plan your osteotomy?
both sides.
So you'll have to do an
Yes.
osteotomy both in the distal femur.
Femur and
Sir, proximal tibia and distal femur osteotomy, sir.
Yeah. So what
open
kind of
wedge.
osteotomy will you do?
Open wedge osteotomy.
In distal tibia, we can do open wedge osteotomy from the medial side or the closed wedge osteotomy from the lateral side, sir.
Okay. So what would you do?
From the medial, from the medial side, sir, open wedge osteotomy, sir, in the
Okay.
femur.
And the
Femur. He's talking
Yes.
about femur.
In the distal
Okay.
femur.
Okay, distal femur, you want to do an opening wedge osteotomy, and proximal tibia?
नहीं, दोनों तरफ open नहीं करेंगे. Sir,
both
we
side,
have to
both
do one
open wedge.
open and one closed wedge osteotomy, sir. So in tibia, sir, we do the open wedge osteotomy from the medial side, and in distal femur, we do the closed wedge osteotomy from the lateral side.
Okay, but why do you have to do different? Why can't you do open on both sides or closed on both sides?
Sir, maybe, sir, we don't know, sir, but some mechanical effect will be lost, sir, if we do the both open wedge osteotomy.
Okay.
Neeraj, you want to add on something?
Sir, we can do, sir, both open wedge osteotomy, sir, from medial sides.
So what
What
will
about the length? Length of the lower limb after open wedge osteotomy on both the sides?
There will be lengthening.
Okay, so there are various things you can do anyway, but generally what is easier, okay, is the tibia is to do an open wedge and the femur is usually to do a closed wedge, yeah? So here we did a lateral closing wedge on the femur and a medial opening wedge on the tibia, okay?
Okay.
There's no absolute right answer here. So now you can see how the limb is nicely aligned. And you see the follow-up. This is, I think, at about 1.5 years. And you can see now how the opposite knee, which was much better, is now looking worse. The space here is improved. And this is the final follow-up at 3 years, 6 months. You can see how nicely he's walking. And his left limb is absolutely straight. And he's got a good gait as well. Okay, so I think we'll do one more case.
Sir, any plan for other limb, sir? Because you have.
Yeah, well, I have advised him an osteotomy in the other limb, but he says at the moment he was not having too much problem, so he is not decided on it. The problem is by the time he'll come for surgery, he'll probably need a knee replacement on that side. So here's a 38-year-old gentleman who presented in the OPD, okay? And he had pain in his left thigh since a year. This is not a pure trauma case, but difficulty in squatting, no other medical or so OPD patient. And you do the x-rays and that's what you find. So what are you thinking of?
Yes, I think Jisan is also here. Jisan, if you want to answer it, otherwise Rajan will tell.
It's appearing like left proximal femur GCT.
GCT. Okay. It's.
Sir, it is most likely it is same as like Jansen's tumors. Most likely it is.
Also
Okay.
bone cyst.
Yes, Neeraj.
Bone cyst, okay. So, what are you going to do to investigate him?
Sir, will sir first this will X-rays.
Blood
There's
investigation.
blood investigations, X-rays.
X-ray followed by MRI.
Investigations, what would
MRI.
you do?
Will you see the localized lesion or is it involving the complete bone?
So complete bones.
It is involving the complete bone, sir.
Oh.
So do you see giant cell tumor like that?
No, sir. Epiphyseal region, epiphyseal and metaphyseal region more common, not diphyseal.
So what
It is
The
it is near to metaphyseal region. It is not at the shaft, sir. We cannot like. It is near to metaphysis.
Yeah,
Okay,
but you
Subhanshu,
look at
you are
the
telling
shaft,
something?
it's going down till here in the shaft, yeah?
Yeah.
Yeah, sir. Okay. Now I can make out, sir. Yes.
Okay,
Yes.
so what investigations? I'm not expecting you to diagnose it right away. So what investigations would you do? You said blood investigations. What blood investigations would you do?
Sir, ESR, CRP, vitamin D tests, and serum
Okay,
ALP.
ESR, CRP, vitamin D to rule out any
Alkaline phosphatase, all this.
alkaline phosphatase. What will it tell you?
Sir, it's bone forming or
Yes, sir.
Or
lytic lesion or
Cyclically.
so you know it's a lytic lesion. No? So the alkaline phosphatase won't tell you it's a lytic lesion. Anything else you want to do?
serum PTH.
Yeah, okay. So that is one important thing to recognize in something like this is that you need to firstly get a proper history, the symptoms, and suspect something like a parathyroid adenoma here, okay?
Yes.
Now, so that's what we thought. We got these things done. We got a serum PTH and we also got a parathyroid scan done. And diagnosis of parathyroid adenoma was made and this was referred to the surgeons, okay? So also these were the other investigations, okay? And those are the skull x-rays. What do you see in the skull x-rays?
Salt, pepper,
Solid.
Okay, what else? What other things you find in hyperparathyroidism?
double margins.
The demarcation between this outer table and inner table, there is a
Yeah, so that's
space
yes.
outer and inner table of the space.
What are the where else do you get signs of on radiology on X-rays of hyperparathyroidism? Anything in the fingers?
Yes, sir.
Subperiosteal hematomas.
I am first.
Fingers में क्या दिखते हो? Phalanges में? हाँ?
Subperiosteal hematomas.
We're talking about radiology. You don't see hematoma on radiology, do you?
Radiology.
Yes.
Janki?
Yes, sir. I think there is lytic lesion on, I think, radial side of fourth digit that I'm not.
Those are the bone scans.
Yes, sir.
And what do you see in the scan?
Just a minute. Yeah.
There's the
Increased
sound.
uptake in parathyroid hormones. Yeah, parathyroid.
Okay, so you can see the huge uptake here in this
Yes.
adenoma. And that was what was found in surgery, a large parathyroid adenoma. Now, once you remove a parathyroid adenoma, what happens?
The symptoms resolve, sir, gradually, sir, without any intervention.
Janki, can you mute
Yes,
people who are not involved?
Yes, sir. I'm just because all who are participating have kept him
Sir,
unmute.
post-op hypocalcemia may be seen, sir.
What?
In post-operative phase, sir, Decreased calcium, sir. Hypocalcemia.
Yeah, hypocalcemia. So that's something you need to watch out for.
Yes.
They need calcium. They often need calcium infusions. Okay.
Yes.
And if you don't this thing, they'll go into things like tetany and all. Okay.
Yes.
Yes, sir.
So that's important to monitor them post-op. And this can even happen after parathyroid excision, after thyroid excision, apparently, even though you try to save the parathyroids. So that's the parathyroid adenoma there. Now, the problem was that it took 3 weeks for the surgeons to do all this. And by that time, this is what had happened to the bone. Okay. Now what?
Jishan. Yeah.
Where's the sound coming from?
Sir, from Jishan's side, I am
Okay,
muting him. Yeah. Yes.
Okay.
So there is a fracture in the neck of femur fracture, sir, on the
Yeah.
left side. And it is displaced, sir.
So that's, you want to get a better X-ray of that? They had actually done an X-ray 10 days earlier, which had showed this, but they didn't bother to tell us about it. So now what do you do?
Sir, the age of the patient.
This patient is 37, 38 or 39. I think.
Sir, we can do a sir proximal femoral nailing, sir. But
You can do that.
the bone quality is very low, sir.
So how will you do a proximal femur nailing with the position of the head?
No, sir, this is neck of femur fracture. We don't do the proximal femoral nailing, sir. We can do this, sir, dynamic hip screw.
What length?
Yes, sir.
What length?
Long barrels.
Long barrel.
Long barrel. I'm talking about the length of the plate.
85, more than 85. No?
Length
Sir,
of the plate.
How many holes? Side plates, sir, is asking.
Yes, sir.
Till what length you want to?
We have to do long PF nailing with anything which is long, because the bone quality is not good till shaft or distal femur.
Okay, so let's see. Okay.
Yes.
So we put you on the fracture table, and what we did was we put this locking plate. We were able to go just beyond the last bit of the lytic lesion.
Yes.
Okay. And multiple screws in the front, in the proximal part. And then, as you can see, with time, the bone quality doesn't come back to normal straight away, but over time, you can see how the bone is now reforming. Okay. And then finally, you can see how it is almost normal. Okay. The cortices are reforming, the bone is reforming. And finally, you can see that it's gone on to heal nicely. It's got a good function. He's able to squat, he's able to sit cross-legged almost with a little bit of a restriction there, and he's able to walk almost normally. Okay. So I think this is a situation where the fixation becomes quite tricky, but you have to plan it out properly. And once you've got a decent fixation, all those lytic lesions, because you've taken out the adenoma, will disappear over time. Okay. So I think we'll stop here. Any questions? Because it's already.
So when we are suspecting, sir, parathyroid adenoma, then the initial investigation, what we used to do is calcium and vitamin D.
You have to do your calcium alkaline phosphatase. Okay.
Yes,
and
sir.
Ideally PTH also, if you're suspecting it, PTH also. But every lytic lesion, you should do an alkaline phosphatase. And if it is high, you need to suspect parathyroid. Okay.
So when it is adenoma,
even if
sir,
something looks like a giant cell tumor, we've had cases which have been diagnosed and operated as a giant cell tumor, which have turned out to be hyperparathyroid or parathyroid adenoma later.
So,
Okay.
so when it is adenoma, sir,
I'm
it is
gonna
only
stop
one
share.
parathyroid gland which is affected.
Usually in an adenoma, it will be one gland. Now that gland may be in different places. Okay. So there are cases where they could be much lower down in the neck. They could be even retrosternal. Okay. And you have to be able to locate it. And that's why the scan is important. There's something known as a parathyroid scan. Okay. Which is the one we saw there, where the parathyroid glands are shown more clearly. Okay. And if necessary, you may need to do an MRI to locate the adenoma. In fact, we had a case, I don't know if you remember, where a girl was admitted with a neck fracture on one side and a trochanter fracture on the other side. And someone had planned, and she had been diagnosed as rheumatoid arthritis for many years.
Sir.
In different parts of the country. She had been to almost every in the country and had been diagnosed as rheumatoid arthritis. And I saw her in the ward. It was admitted under one of the other consultants. And I said, this is parathyroid adenoma. She was actually down to, for even, they planned to do a THR on one side because there was a very subcapital neck fracture on that side, and with rheumatoid, etc. They felt that total hip replacement was necessary.
She was treated for rheumatoid since long, sir. And she was on it.
Yeah. And then the first surgery, they missed the parathyroid. They took out the parathyroid, but they missed the adenoma. And so her calcium out at that time. I wasn't there the first time the surgery was done, but I came back and people were going to just leave it at that. I said, no, we need to explore it again. So I got the surgeons to explore it again. And they found the thing was lower down in the neck. And this time everything got back and all her fractures healed by the end of it. So we were able to save the head in that patient who otherwise she would have had a total hip replacement and would have still had a problem because she would have probably fractured underneath it sometime.
Yes.
Okay.
Yes, sir. Thank you very much, sir. It was great.
I think we'll call it a day.
Yes, sir. Thank
you very much, everyone. And next week we have an interesting talk by Dr. Ganjwala from Ahmedabad, who's going to talk about how to create animations and diagrams to help improve your presentations. So I think all of you should be keenly watching it and you'll be tested on it afterwards. Okay. So, okay. Thank you.
Thank you.
Thank you, sir.
Thank you very much, sir.
Brown tumor sir, वो finger में जो parathyroid hormone brown tumor वो parathyroid hormone in fingers अगर होता है तो
yeah, we'll discuss that one. Sir has just now left, so
हाँ sir वो तो बता
we're closing it. Yeah.
Okay sir. Bye.
Thank you. Yeah.
Thank you.
Thank you.